Greetings! My name is Dr. Daniel Rieders, and this is my first YouTube video. I hope by the end you don't say, don't quit your day job. While we're on the topic of day job, my day job is electrician of the heart. Most cardiologists are plumbers, and I'm an electrician. So they stick little tubes into the heart, or they're non-invasive, but they actually don't go in the heart most of the time. They go in the arteries that feed the vessels outside the heart. So some of us refer to them as luminologists, but they're really master plumbers. And I'm a master electrician. You need electricity for the heart to work properly and synchronously. This presentation is educational only, and the purpose of this presentation is to show you how I do an atrial fibrillation. There's early and late atrial fibrillation, and we will be talking about that in a little bit. Ablation of atrial fibrillation around the world is generally performed doing a procedure called the pulmonary vein isolation procedure. The reason for this is that atrial fibrillation begins outside the heart in the veins that feed the left atrium. These veins are called pulmonary veins. There's really no reason that I know of why a vein would have electrical activity. The heart needs electrical activity because that's what tells the muscle to squeeze. Veins don't need to do this. So this is an aberration. There's actually more to the story than that, but whether it's early or later or late atrial fibrillation, around the world the primary procedure is to electrically isolate the veins from the left atrium from the heart. As you get more advanced atrial fibrillation, you have to ablate other areas because the chambers start dilating and scarring. Atrial fibrillation begets atrial fibrillation, so that early on, all that will be needed for a cure may be just pulmonary vein isolation. We isolate the vein in a patient. We may not know exactly how late they are early, and then we see if there's any other sites that need ablation. It's when we counsel patients what kind of procedure we're planning, we always tell them pulmonary vein isolation, and then we'll look for other areas. It's just more likely than not that the later the AFib, the more diseases in the atrium and other chambers, the more ablation that will be needed to be done. And what we want to do is just the right amount of ablation, not too much, not too little. So let me define a few terms. The first one is atrial fibrillation. The heart has 4 chambers, 2 in the back on top called atrium, and 2 on the bottom in front called ventricles. Atrial fibrillation is when the 2 top chambers shake. So when they're shaking and beating 300-400 beats a minute, maybe more, maybe less, they're not able to squeeze at all, and so they're basically at standstill and they're just quivering, and so there's no transport of blood. When there's no transport of blood, blood can stagnate and you can get a stroke. Thus we put patients on blood thinners. Also there's a cable that connects the 2 top chambers to the 2 bottom chambers called the AV node and His bundle. So normally it has a simple job where the atrium depolarizes, it squeezes, it goes through the cable, and then the ventricles depolarize, so you get a lub-dub. In the frame on the left there are up pointing yellow arrows. Those point to the little P waves, which are atrial depolarization. And then the larger figure next to them are ventricles, and so you get a lub-dub, lub-dub, lub-dub. On top there's an arrow going down showing that the atrium are electrically chaotic, and so the cable fortunately doesn't let 300, 400, 500 beats a minute go down. In the bottom chambers, that would cause ventricular basically standstill of blood transport, and that you would die immediately. So this cable protects, but as you can see, the ventricles are beating at an irregular rhythm then, which can cause problems itself. So this condition where the atrium are chaotic and shaking, quivering, is called atrial fibrillation. If the bottom chambers would quiver, this would be called ventricular fibrillation, which, when you have rapid ventricular beats, this is the #1 cause of death in any country that's modern around the world. It's the #1 cause of death, and it's called sudden cardiac death syndrome. This is a different topic, perhaps my second YouTube video. We've defined atrial fibrillation. Let's now define what an ablation is. Quite simply, it's when a catheter is placed, usually within the heart chamber, against the wall of the heart, and through this catheter energy is applied that burns or dries out the tissue so that it can't propagate an electrical signal. It becomes electrically silent and it will turn to scar tissue. This is required to isolate veins and to fix other short circuits in the heart, and is used to cure people of heart problems, heart rhythm abnormalities. The catheter we use is a very special catheter. It has irrigation. That means fluid comes from outside the body and irrigates out the tip. It's called an open irrigation system. This cools the tip. It's a cool tip catheter. Also, we use three-dimensional positioning so we can make a three-dimensional map utilizing a mapping software, so that we can depend on our catheter map instead of X-ray or other maps. When we burn, the electricity or power energy, which we usually use as RF, returns back out of the patient through a patch, usually on the back, and then goes to a machine that supplies the energy, and it's controlled by dials and knobs and a foot pedal. So an ablation has a complicated system with a very sophisticated catheter, and it's used to cure rapid heartbeats, tachycardias, specifically atrial fibrillation in this presentation. Preparing for your procedure. We've already done a lot. We've told you what the procedure is about and what the problems are, and you'll see more. But there's important things to know and important expectations. First of all, it's important to be NPO after midnight. That means nothing to eat or drink after midnight. We use anesthesiologist anesthesia, and they're very particular. Some are more lax, some aren't. But to be safe, it would be better not to drink or eat anything after midnight. Then you will conform to every anesthesiologist's safety rules. We inform the patients that a lot of times the morning medications you can take the night before. An important exception is the diabetic medications, which will need to be tailored. And if you have heart problems and lung problems, that will need to be addressed. It's very important that if you're on warfarin, otherwise known as Coumadin, do not stop that. But if you're on an alternative blood thinner such as Pradaxa or Xarelto, you need to stop that. The reason is that there's no man-made antidote for Xarelto or Pradaxa at this time. With warfarin, there's several remedies and antidotes. We prefer keeping patients on warfarin because we can decrease the risk of stroke with that, which is not possible with Xarelto or Pradaxa, because of if there was a bleeding issue, we wouldn't have a remedy for that. It's also important, if you can, to come at least a day or two before the procedure and get all your registration, finances and paperwork out of the way, lab testing, blood, urine, whatever, before the procedure, so that the day of the procedure you just show up on time, and then we will go from there. It's important also to remember that when you come for your procedure, you're going to spend the night. Everybody spends the night after an AFib ablation in my lab. It's important to weigh yourself before the procedure and when you get home. If you have heart failure, we recommend that for patients in general. Generally, we say, wake up in the morning, eliminate, urinate, and then weigh yourself. And that's your weight. Mark it down somewhere. Come and have your procedure. When you get home, weigh yourself again and see what the weight difference is. We give a lot of fluid during the procedure, and a lot of patients can have fluid overload problems after the procedure. And the most accurate way to know that would be at your home with the scale. We also have home health nurses that can help with your care afterwards, and we'd like that arranged ahead of time as well as your follow-up appointment. It's important to be on time the day of your procedure. That's a firm number. Suppose your time you were set to be there was 6 a.m. and they told you your procedure start time would be 8 a.m. The 6 a.m. is a firm number. The 8 a.m. is just a slot. It doesn't mean anything. Your procedure could start other times. So that's not meaning anything. It's just a slot. Also, you'll be having people ask you the same question over and over again, like allergies, your history, this and that. Please don't get irritable with them. This is their job, and this is done for your safety. The day of your procedure, I'll be in the background coordinating your entry into the lab, and when you get into the lab, your procedure. If you don't see my eyeballs at this time during the procedure, don't worry, I'm there. What will happen is when it's your time, you'll have IVs in and they'll bring you into the lab. You'll be sitting up and they're going to put all kinds of patches. The picture of the patches here is really understated. You'll have 2 or 3 times the amount of patches on you. We monitor a lot of things. Then you'll lie down and they'll put you to sleep, and then your groin areas will be prepared and draped sterilely. You'll be asleep by then. Then this is how I'll greet you in the morning. Your groin areas will be exposed and sterile, and this is my workspace. This is where I stick the catheters into your veins, just like an IV in your arm, except these are a little larger, and this is how, through a diaphragm, we pass these tubes through the veins up to your heart and perform your procedure. This is my workspace. Occasionally we'll work in the right neck area also. So there's some instruments laid down on a sterile table. Those long sheaths are just IV sheaths, but they're longer and they go directly into your heart. The shorter ones, the green ones, are just put in at the beginning. We give heparin and then we exchange them out for the longer sheaths. The purple one goes in the left groin, and that has a wider caliber because we put an ultrasound probe in it to image your heart during the procedure. The ultrasound probe is coiled up in the right upper corner, and then there's guide wires on the right lower corner. These we use to pass everything over when we advance our sheaths, because the wires are atraumatic and it will guide the sheaths where we need them to go. There's a lot more to this than this displayed, more disposables. There's some important pieces of equipment that I'd like to introduce you to. One is this circular catheter. It's called a lasso, and it has electrodes around, and we can make the lasso, the circle, bigger or smaller from the outside by an adjustment tool. This we put inside the vein, and then we open it up or around the vein area, and this is how we target the electrograms, the areas to ablate, and this makes for a much more efficient procedure. Also with the circular catheter, this is the most efficient way to show that the veins have been completely isolated, which is the primary objective. Seeing an isolated vein is the beautiful picture we're looking for in every single vein, procedure. The other catheter is an ablation catheter, which I'll show you a little bit more in the near future. We showed you a little bit before, and that is a special catheter with three-dimensional navigation, irrigation, sensing, pacing, and burning capabilities. The next portion of the procedure is where I actually start laying my hands on you. It's called instrumenting. That's where we insert our equipment. So this part, I first stick at least 3 IVs into the groin. We usually use a big IV line in the left groin, which is a purple color, and then 2 green ones in the right. What we do is we numb up the area. You're already under anesthesia, but we actually also use local anesthesia. We stick a needle in the vein, stick a wire through the needle, pull the needle away, and then we stick the plastic tube over the wire so that it goes through the vessel where we want it to go. We pull the wire and the dilator out, and then you have a tube inside of your vein, which is also a tube with a diaphragm at the end. And with this we can introduce catheters into the heart, or into your system at least, and then go from there. So here, jumping ahead, we have 2 green sheets in the right groin, which is on your left, on the patient's right, and there's a diagnostic catheter up through one of them, going up to the heart, making certain measurements. And then on the left groin, which is on your right, is an ultrasound probe that's in the heart. And we monitor and map the heart from there. This is my workspace. The next thing we do is we look on an X-ray screen, and yikes, this is all we see. It's hard to really see much. On the left picture, however, it's up front. You can see some sternal wires where this patient has an open heart surgery, and the right picture shows the camera tilted in what we call LAO direction. You can see our diagnostic catheter in a little vein going toward the patient's left, your right. This is in the coronary sinus, and then if you look closely, you can see the ultrasound probe right near the bottom of the heart, just barely entering it. The problem is that we really don't see much with these, and the procedure I'm going to show you is a very intricate, delicate procedure, so we have to have better imaging than this. I'd like to now make a few introductions. This is the layout of the room. This is the team. Some team members are shy, they didn't want to be photographed, but up at the top of your head is an anesthesia team. There's all kinds of machines we use and monitors. We have generally 2 or 3 technicians sitting at computers making certain measurements. There's me, the back of my head, I'm looking at many monitors, and that's how the room is set up. This whole team works in synchrony. I've had visitors come to the lab during procedures, and what they say is that it's like a symphony. There's absolutely no stress. It's 0 stress zone, and everybody knows their job, they're responsible, and they're working as a team together. And it's pretty amazing. This team I'm extremely proud of. So I foreshadowed that we needed to have a better image, and one of these better images is an ultrasound probe. We monitor and map the whole procedure using an ultrasound probe. This is a very special ultrasound probe. In the left frame you can see an arrow pointing to the left atrial appendage. When people have AFib, this is where we believe most of the strokes occur. And then you see the left atrium right above it. To the right frame you see these little dots. We can actually tag things in 3-dimension. This has 3-dimensional imaging, GPS if you like, and these actual dots are in 2-dimension, but it's actually a 3-dimensional picture. In this next frame you can see the left inferior vein, the left atrium, and then at the top of that frame is a thin area. That's where we do our transeptal puncture to get access to that vessel. We can even tag things outside of the heart. For instance, right here we're tagging the esophagus. That's important to know because we don't want to burn the esophagus. And this lays right across the back posterior side of the left atrium. Just to demonstrate the 3-dimensionality, we're actually spinning the frame on your right, showing that these are 3-dimensional points, and meanwhile you can see the mitral valve, the left atrial appendage, the veins, and you can also see a circular catheter inside of our vein. Now we're ready for the transeptal procedure. This is where we gain access into the left atrium. If you notice on the frame, there's the left atrium. You can see a needle against the thin part of the septum, and we can look at it in different dimensions. So now we're ready for the transeptal. We've put the needle on the thin part of the septum, we imaged it on ultrasound, and then when we're at the right spot we add a little bit of energy, and this, there it goes, and now we have access. The catheter's right there. With this technique we don't have to apply any pressure, and it makes for a very safe, reliable access to the left atrium. We do 2 of these. Now the next portion of the procedure I call making the map. We have 2 catheters, sheaths in the left atrium, and this is where I become a master painter instead of a master electrician. It's part of the job, both of these things. I start with a big paintbrush and then I move to a smaller paintbrush to get fine detail. My belief is the more accurate the map, the safer and more effective and better outcome the patient has. So I start with a big paintbrush, the circular catheter, and I move it around in the chamber. If you notice, there's a little bit of lag time between when I move the catheter and it's taking points. The computer is very sophisticated and it takes time for them to make a matrix. Also, we gate this to respiration so that it'll only take points, the computer, during a certain phase of respiration. And so during the other phase it won't, so that the map is very accurate and doesn't have respiratory variation, because the heart will move in the chest when the diaphragms move, and this will make for a map that is not accurate. Then I put a smaller paintbrush, the ablation catheter, in, and I start making the fine details. Some of these catheters can deform the chamber, so we can have one of the technicians Photoshop that away and get a true 3D dimension of the heart. This is just moving the catheter and defining where the walls of the heart are, the vessels, and making a beautiful map. So this goes on for a while, making this map, and in the meanwhile I'm directing the technicians, and we have a really good dialogue. Then my Photoshop guy gets to work, and he makes the picture make sense. So he or she correlates where the ultrasound took the orifice points, where the atrium and the veins meet, and with that we remove the veins, make them different colors, and also tag the left atrial appendage, which we usually do in a red. We don't want to be inside the appendage, and we don't want to be inside the veins. The little pointed thing at the bottom is where we did our transeptal. And so here they are going away, working at the image here. Correlating ultrasound points and integrating that into our 3D map that I painted with a big brush and then a little brush. So let's just watch and see what's going on. All right, that's red. That must be the left atrial appendage there. And there's a purple. That's the left common. This patient looked like we imaged one vein, so we did our integration, calling it a left common instead of a left upper and left lower pulmonary veins. And then we'll be working on the right inferior, which will be tagged, in this case, green. And then the right upper, and then we'll be defining where the valve is and creating a hole there where the mitral valve is, which leads into the left ventricle. So there we go, working away. On the left frame, that's the back of the left atrium, and you can see the purple for the left pulmonary veins, the green for the right inferior vein, and then above that will be the right superior, and then peaking at the top is right in front is the right atrial appendage, which is in red. All integrated. As you can see, this is a much better image than an X-ray image, and adds for safety and accuracy, better patient outcomes. Here comes the valve part. And there it is. So we can turn these images in all directions. You can't do this with X-ray either. And so we're rotating. We can see through the valve into the heart. Looking at the back of the heart on the rotation. Coming around front again. A right valve, and then we're done. It's important to do this for every patient because we want to make sure our catheter is right against the wall, and this helps show us where we've been, where we're going, and where we are. This is another patient just showing that the anatomy can be quite different depending on the patient. This patient has very different anatomy. So believe it or not, we're still preparing to do the ablation. And now that we have a beautiful, accurate map, we're going to move into the ablation portion. I just would like to reiterate that this procedure is a pulmonary vein isolation procedure. On every AFib patient, we isolate the veins. In an early AFib patient, that's pretty much all we need to do, with exception. And the more advanced AFib, the more areas we need to ablate. And the cure rate thus goes down. Just to remind you, this is where we do the ablation, the burning, and this is the therapeutic portion of the procedure. This is what all the preparation has led up to. The ablation, the intervention, the fixing, the cure. In this slide, we can see the circular catheter in the left common pulmonary vein, the appendage close by, and this is what we image. We can see where our catheter is, our ablation catheter, and we can accurately tag the circular catheter poles. We can number them 1 to 20 if it's a 20-pole catheter, and then if the 20 looks like it's the most active, then we can aim our catheter right for that 20, pole 20 in 3 dimensions, and do our ablation there. It's quite scientific. This is just more of the same, showing as a procedure progresses how we target different areas in 3 dimensions to eliminate the electrograms on the circular catheter, which are not displayed, but I will show you them in a brief moment. This frame shows at the beginning all the poles of the circular catheter. On the left one we see electrogram is this patient's in a normal rhythm at the time, and we see electrical activity in every pole. The middle frame shows our ablation catheter against one of the poles, and if you can see, it's going like crazy because we're near there and it's causing that electrical artifact. And then when we're done, you can see that this vein is isolated. In fact, it's silenced. There's no electrical activity in the vein at all. So this big left common pulmonary vein was completely silenced. And this is what the beautiful picture is. Not our 3D image, but the silencing or isolation of the vein. This particular patient also required isolation of the posterior wall, which was done. And this is just another frame showing you that on the right side of this frame that there's no electrical activity in the vein. This vein has been silenced. So now that my part of the procedure is done, we take out the catheters, we remove the sheaths. Sometimes we put a stitch or a closure device to help stop bleeding. Remember, most patients are on warfarin, and we've given strong blood thinners during the procedure. We also reverse those blood thinners at the end. We usually give a diuretic, a water pill to remove all the fluid we gave during the ablation to cool the tip of the ablation catheter, and sometimes we give a drug called solumedrol, which can decrease the inflammation, because as we do this procedure we believe that there's an inflammatory process that begins that takes up to a couple months to heal, and if we can help resolve that early, that maybe the patient will have a better time after their procedure. So this is what we do, and there's a lot of things that you should expect after the procedure. A couple housekeeping points. You will spend the night. You probably will not see me after the procedure, but I'll definitely see your family or friends or who's ever there. They're usually in a waiting room, which we use every time. You'll most likely go home in the morning unless there's an issue. We'll hopefully get a home health nurse to come and visit you. When you get home, please weigh yourself, and please weigh yourself the next morning after you urinate, so that we really know what your fluid status is, to see if you have excess fluid on you. Hopefully you will already have a follow-up appointment with me. Nurses will come to your home. A couple things to expect. Some people feel terrific immediately after this procedure. A lot of patients feel kind of really bad for the first 2 days to 2 weeks after the procedure, and sometimes very few patients that last longer than that. I believe it's from this big procedure we did and the inflammatory process and all that they've been through during this procedure. So if you feel like a Mack truck ran over you for a couple of days after procedures, that is really expected. We'd like to know about it, but don't be upset. Also, a lot of patients have chest pain after their procedure. Usually it's described as when I take a deep breath it really hurts, and different positions make it hurt worse. What we really need to know about is if you're having trouble swallowing, or it's like food or water or your pills, we really need to know about that, because that could signify damage to the esophagus, which would require more intensive therapy. So hopefully you'll see me in about a week in my office. Nurses will be sent to your home. We may request an outpatient echo, ultrasound of your heart. A lot of patients can have arrhythmias after this procedure and they're actually cured, but because of the inflammatory response, they have all kinds of funny heart rhythms. So most of the time we think these can continue up to about 3 to 6 months. Some patients don't have any. So if you're having AFib even, or irregularities of the heart, don't worry. This is very common after a cure. Well, when to call the doctor? That's simple. If you have any concerns, call my office, call me. I want to know about them. There's some things that would be very important to call us. If you're dizzy or passing out, if you have some neurologic symptoms, such as loss of speech or paralysis, if your bleeding from anywhere, if you're having trouble swallowing, if you're not feeling well, if your warfarin level, if that's what you're taking, is less than 2.0. If you feel unsafe or you have any concern, please call me. I want to know about it. This brings us to the end of this presentation. The purpose of this presentation, the intention, is to make you feel safe and that you're going to be well taken care of by an expert team. Thank you. I am really grateful that you took the time to go through this presentation. If you have any questions or concern, please contact me and my office.